Uh, it's really great pleasure for me to introduce Dr. John Leipzig. Before I do introduction, I want to say he has nothing to disclose. I just want to make sure you know this, unless he adds something later on. He will be talking about bipolar disorders in children and adolescents. As you know, it's an important topic and controversial topic. And we have some of our child psychiatrists from the community who can also contribute to the discussion. Dr. Leipzig, he did his medical degree at the Medical College of Virginia, Richmond, and then he was at Tufts University, Boston, to do his internship, and adult psychiatry residency at St. Elizabeth Hospital in Boston. And he did his child psychiatry fellowship at University of California at Davis. Then he, came to California and involved in doing clinical work, private practice, some forensic work. And then he said, I'm going to go in academics. He changed his, I'm glad he did that. And he's now, in charge of our pediatric CL program here, and also he works at CRC, that's Crisis Response Network at UPH South, South Campus, University South Campus. So with that introduction, I really, we can welcome him to, he's a newest member to our faculty, and it's nice to have him here.
Thank you. Thank you, Hari, for the warm introduction. And I'm very happy to be here. I'm the new guy, the new kid on the block at the Child Psychiatry Department, and I hope that I have some new information to share with you guys. Thank you for taking time from your busy schedules to join us today. So what we're going to talk about is bipolar disorder in children and adolescents. It is a topic that definitely has some controversy to it, and I hope that the slides and the discussion will expose some of the controversy and some of the factual information that we actually have, that we know. And I come from clinical practice. Over the last 15 years, I've been working with children, adolescents in private practice, so I've seen a number of kids with bipolar disorder. So I hope to have that information to share with you guys. Also, we'll try to keep the questions to the end, but if you have any quick question, you can ask me as we go along. As Dr. Guman said, I have no conflict of interest to disclose, no drug company money or relationships have gone into producing this talk. So first thing that we want to talk about is the scope of the problem. What is the epidemiology? How big of a patient base are we looking at? And a number of community studies have been done looking at the prevalence of mood disorders in children and adolescents and mood symptoms. There was one study of older adolescents showing that the lifetime prevalence for mood disorders at 1.4%, and the majority had bipolar type 2 and also cyclothymia. Another study done by Gabriel Carlson in '88 of 14 to 16-year-old youth showed the prevalence of mania at 0.6%. Now, mania, as we know, is a hallmark symptom for adult bipolar disorder, but as we'll see, it's very different in presentation in children and adolescents. One thing that we do know, if you track the history back from your adults with bipolar disorder, you'll see that there were some symptoms that occurred earlier in childhood or in adolescence. Most of the time, that first episode is depressive, so we have to be very careful in treating depression that we're not activating a latent bipolar disorder. If you survey adults with bipolar disorder, you'll note that many have the onset in adolescence and childhood, and Jameson found that only 3 to 5% of patients had the onset below 10 years. So it is a rare condition. However, what we've seen in the last 15 years is that the diagnostic rates have gone way up. If you look at, this is a different Dr. Moreno, I think, unless this was you. Moreno, 2007, show that the number of annual office-based visits of children and adolescents resulting in a diagnosis of bipolar disorder increased from 25 to 1,003 per 100,000 population. So something's going on here. Is the actual incidence of bipolar disorder increasing in children and adolescents, or is it the diagnosis? And the explanation is probably it's the diagnosis, because it's probably the actual diagnosis rather than the condition. It may be that the diagnosis gets labeled because of insurance reimbursement reasons or hospital admissions because it's reimbursed at a better level. So what we're trying to do now in the field of child-adolescent psychiatry is specify much better what actually is bipolar disorder. Another reason that it's very important to come up with a better set of diagnostic criteria and better specifiers is that 90% of kids that are diagnosed with bipolar disorder receive psychotropic medication. And it's not just light-duty psychotropic medication. Oftentimes, it's what I call the big guns, which are mood stabilizers, antipsychotics, second-generation antipsychotics, and mood stabilizers. Some of the studies that are beginning to produce good results are the longitudinal studies. And what we're finding in the longitudinal studies is that not all of these kids that are diagnosed with bipolar disorder go on to become adults with bipolar disorder. If the condition actually has specificity and a descriptive validity to it, you'd think that childhood bipolar disorder would turn into adult bipolar disorder. However, one longitudinal study with 413 kids aged 7 to 17 showed that 2.5 years after onset, 81% were fully recovered, and 1.5 years later, 62.5% had syndromal recurrence, primarily depression. So the criteria for bipolar disorder doesn't seem to hold in terms of diagnostic stability. We'll look into that in a little bit. Again, if you look at retrospective results, what was the age of onset, you find that 30% had an onset of their mood disorder before 15 years, 25% between 15 and 19, and 40% of people with bipolar disorder onset above age 20. What are some risk factors for pediatric bipolar disorder? So twin, adoptive, and family history studies are the typical ones that are looked at first to discover if there's a genetic basis. Because if there is a genetic basis, it will produce a signal in the families. What we found is that there's a strong genetic component with 4- to 6-fold increased risk for first-degree relatives. Another thing that you find is that dysthymic, cyclothymic, or hyperthymic, I call those the thymic triplets when I'm teaching residents about the different thymias, dysthymia, cyclothymia, and hyperthymia. And then I guess you would call them quadruplets if you mix euthymia in there too. So I like those thymias. And hyperthymia is one that doesn't get mentioned enough, I think. And what you find is sometimes those temperaments presage an eventual bipolar disorder diagnosis. Another thing is that offspring of bipolar parents show some differences in their mood lability, anxiety, attention problems, hyperarousal, depression, somatic problems, and school problems. That's from Kiki Chang. He's the director of child adolescent psychiatry at Stanford. We're not going to go over this whole slide, but it's nice to have a picture of the brain. And what it shows on top is normal gray matter development. In the middle is childhood onset schizophrenia, gray matter development versus healthy patients. And what you find, the brighter areas like the pink and the red are differences in the brain development. And what you find is that there is slower development and less development in the frontal lobe. And a similar pattern is seen in the bipolar gray matter development on the bottom. So one way to understand the neurobiology, and we could go into this in a lot more detail, but this is not a neurobiology of bipolar talk, so we'll go over it quickly. The frontal lobe seems to play a pivotal role in certain child psychiatric conditions, especially ADHD and bipolar disorder. The neuroimaging is showing that there's an overlap between these two disorders. As we know, the frontal lobe is the executive part of the brain and controls executive function. What the functional MRI and the volumetric MRI studies are showing is that abnormalities can present in bipolar children before the development of mood symptoms. But it's not yet a biomarker. This is just a review of the few different systems in the brain. The frontal dopamine pathway, the nigrostriatal dopamine pathway, and the mesolimbic pathways. Those are different dopamine pathways. The frontal one is the one that projects to the frontal lobe, and that one is most involved with ADHD, development of executive function. And if we oversimplified the condition, you could think of bipolar disorder as involving too much limbic activation and too little frontal lobe activity. And something may be happening during development that the limbic system is activated and the frontal lobe is not compensating or able to control the emotional reaction. There's also other areas of the brain involved, of course. The hippocampus seems to be underactive, and the amygdala, which I think of as the panic button in the brain that triggers the fear response and the fight or flight response, the amygdala is overactive. We're going to move now to early diagnosis, why it's important. One reason that early diagnosis and assessment of pediatric bipolar disorder is important is because it's a unique condition that leads to severe disruption in the child's family life, in their school performance, their development, and peer relations. Another thing that's important in diagnosing and identifying it early is sometimes referred to as the kindling reaction, and that's a term borrowed from neurology where smaller seizures or more frequent seizures lead to more frequent and a worse condition. The same model is used in childhood bipolar where multiple episodes can presage a more treatment-resistant condition. So we want to identify it early and begin intervention when we can so that it avoids a worse condition and more psychosocial disruption further down the line. The other thing with kindling is that patients may be more treatment resistant later on. So if you can identify them early, you can have a better outcome. And of course, there's a higher incidence of suicide attempts, drug and alcohol abuse, and so on in bipolar disorder. So if you catch it early, you can prevent some of that dysfunction and hopefully save the person's life. There are diagnostic criteria for bipolar disorder from the DSM-4. However, those criteria are not age-specific at all. So what we child and adolescent psychiatrists have had to do is to modify those to meet the needs of our younger patients, and it's not always translatable. It's one of the drawbacks of DSM is that it's a cookbook, in some ways a checklist approach, and it doesn't really meet the needs of child psychiatrists in diagnosing these conditions. So there's a lot of work that's being done looking at specifying the diagnosis and differentiating it from other childhood conditions that present with mood irritability, explosive outbursts, and so on. So what we do is we look at individual symptoms and perhaps sub-threshold presentations. So we find more atypical cases. You're not going to find a kid with bipolar disorder that meets DSM-4 criteria. They might meet some of the criteria, however, we'll see that they do not have defined mood episodes like adults do. The atypical presentations are much more common, such as elative, expansive, irritable mood, and especially what we call mixed mood episodes. That's most commonly what you see is mixed mood episodes, rapid cycling. Furthermore, there's a significant overlap with other conditions such as ADHD, oppositional defiant disorder, drug and alcohol abuse, and so on. So there's very few pure childhood bipolar cases because they overlap significantly with other things. So what would bipolar manic symptoms look like in a kid? We know what they look like in adults with expansive mood, euphoria, pressured speech, and so on, but you very rarely see that constellation purely expressed in kids. What you see more often is the elevated, expansive, euphoric mood mixed with irritability. And that irritability word you'll hear frequently throughout this talk, and that's something to keep in mind because that irritability seems to be one of the hallmark features. We see it in adults with bipolar disorder. I always say as the euphoria and the pressured and the expansive mood starts to peak and the adults aren't getting what they want, then they become very, very irritable, as was this woman Sunday night that I dealt with all night at the CRC, who probably spouted every bad word in the book. She was extremely irritable, but it was only after days and days of her mania, as she started to burn out those neurotransmitters, wasn't getting what she wanted and hadn't been sleeping at all, the irritability peaked. Well, you see it much earlier with kids. The other thing that you see is the outbursts, not just reckless risk-taking behavior that you may see in adults, but another hallmark feature of childhood bipolar disorder are outbursts that are sometimes called rage attacks. You may see other things like racing thoughts, grandiosity, flight of ideas, distractibility, increased goal-directed activity, and so on that occur in adults. But one thing that's very different in kids is that these episodes may be rapid, they may be brief, and they be mixed, as we said. They may have an up mood and a down mood at the same time. Sometimes this is referred to as dysphoric mania. I don't know if everybody knows that term, but it's a term that I picked up somewhere, and it's pretty applicable to these mixed mood states. There's a few adults that have atypical bipolar that have that type of dysphoric mania. I like it as a term because it describes the mania, but at the same time the person's unhappy. It's not like a euphoric type of mania that we're used to training for. Besides the manic symptoms, which are more rare, the depressive symptoms are much more common. And the other thing, as a community psychiatrist that I would see in private practice, is the depression as a first presentation of childhood bipolar disorder is much more common. And you always have to keep your clinical intuition going and keep your ears open for any symptoms of activation. When you're treating these kids with bipolar disorder, they may get activated because of the serotonin reuptake inhibitors, or you may be triggering a latent bipolar diathesis. So that's always very important to keep your eyes and ears open for. Another finding is that preschoolers with depression have higher family histories of bipolar disorder, and there may be a subtype of kids with depression that have a family history of bipolar disorder that you have to be very careful with. So what are these rage attacks that we were talking about? Rage attacks are an extreme form of temper tantrum. One way to think about it is it's the worst temper tantrum you've ever seen. However, it goes beyond that into other terms that we use, such as outbursts or meltdowns. They aren't specific to bipolar disorder because there's other causes as well that you have to be aware of and be clinically astute to try to differentiate. Are the rage attacks because of personality rigidity or perhaps a developmental condition like pervasive developmental disorders, or is the child on the autistic, Asperger's spectrum? Could they be obsessive compulsive and they have outbursts when they don't get things lined up exactly what they want? There's also temperamental differences that occur between parents and kids. Other symptoms, syndromes like depression, anxiety, PTSD, ADHD can lead to outbursts as well. Sensory integration disorder, which overlaps with the pervasive developmental conditions as well. And are rage attacks part of bipolar disorder, or may be they're a separate thing? If they're a separate thing, they might also be helped by some of the medications we use for bipolar disorder. So what the folks at the Academy of Child and Adolescent Psychiatry and the American Psychiatric Association are trying to do is to separate out and tease out what are these rage attacks and what is the element of irritability within bipolar disorder. Is it a separate condition? And the next few slides we're not going to go over in complete detail because there's a lot to this condition. I got these off the American Psychiatric Association DSM-5 criteria website. There's a condition that's being labeled now disruptive mood dysregulation disorder. The reason the APA and the DSM folks are looking at this condition now is so we can get away from labeling kids with bipolar disorder. So what I find is that once a child is labeled bipolar, it's a big diagnosis for little kids, and that label tends to stick. So I've tried to avoid it when I can. One of my colleagues in Northern California wrote an article that was an editorial, and he said, let's get off the bipolar bandwagon. And it was well put, because he said so many kids that presented to him in clinic after their hospitalization had a diagnosis of bipolar disorder, and he only saw that that diagnosis was appropriate maybe 10% of the time. So this category has its own controversy associated with it, disruptive mood dysregulation disorder. But what they're trying to do is to separate out the rage attacks and the temper outbursts from a true mood disorder. What they did is group the recurrent temper outbursts into description, verbal or behavioral or physical aggression. The reaction is out of proportion to the situation, and the response is inconsistent with developmental level. So they describe the anger attacks, and then later in the criteria, there's a description of the mood between the temper outbursts as being persistently negative, irritable, angry, or sad, and this negative mood is also observable by outside people. And we are certainly not going to go over all the criteria here. The reason I included it in this section here is to show how many words it takes to try to describe this syndrome and differentiate it from bipolar disorder. That the Academy and the bright minds that are looking at this condition are doing their best to determine, is it a separate condition, or is it part of bipolar that needs to be described in a different way. So a better slide is this one right here. Okay, this is a nice summary then. There was a good paper by Ellen Liebenluft who described severe mood dysregulation and tried to separate it from what we consider bipolar disorder. If you think about what is severe mood dysregulation, it's an abnormal mood of anger or sadness that occurs most days, and it's severe enough to be noticed by parents, teachers, or peers. So it is observable by outsiders, not just a description by the child themselves of what's going on. There's an increased reactivity to negative emotional stimuli at least 3 times a week for the past 4 weeks. There's hyperarousal symptoms which overlap with ADHD, such as insomnia, physical restlessness, distractibility, racing thoughts, thank you for coming, or flight of ideas, pressured speech, or intrusiveness. There's an onset under the age of 12, and severe mood dysregulation may encompass ADHD and oppositional defiant disorder. So kids with severe ADHD or with oppositional defiant disorder may also have this severe mood dysregulation. And that's an important distinction because some of those kids that present with outbursts, irritability, negativity, oppositional behavior, and so on definitely need help. It's good that they came to see us. However, it's a disservice to label those kids with bipolar disorder because that's not what they have. So that's what the current findings and the current direction in the field is going towards. Let's not label everybody with bipolar disorder. So what are some other differences from adults with pediatric bipolar disorder? We mentioned some of these mixed moods, such as the manic, driven, and depressed at the same time. So they're up and they're down. There's multiple daily cycles of highs and lows. What we see in kids and teenagers with mood disorders, or affective instability, as I like to call it sometimes, is a more chronic course without intervening stability. With adults, there's more of the bipolar sine wave where there's the up, and then there's the down and the up. It's more of a neatly chartable condition, but you don't see that in kids or teenagers. It's more of a chronic course and they don't have that intervening stability. There's the continuous rapid cycling over longer periods of time, and the other thing is that the condition tends to be more treatment resistant. And we'll get into treatments in a little bit. So we see more irritability, less euphoria, more rapid cycling, more mixed states. ADHD is more likely. There's a greater family history of bipolar disorder. And another way to conceptualize this, is it a different condition? Is it a different type of presentation, such as in diabetes, there's juvenile onset and there's adult onset. And they're both diabetes, however, there's differences between the two. We might be looking at pediatric juvenile bipolar disorder as a different breed of cat than adult bipolar disorder. They have some, hello girls, welcome. They have some differences, but at the same time, there's an overlap. So what are some diagnostic pearls that we look at in diagnosing pediatric bipolar disorder? This slide used to be labeled clinical clues to diagnosing bipolar disorder, but I changed it to clinical diagnosis. What are some things that you might want to look at? Early onset and family history is important because that confers some genetic load. The child may exhibit intense separation anxiety, combativeness, emotional lability, school phobia, odd behavior, or unusual responses to trials of stimulants used for ADHD. That's another reason to be astute and try to look for a mood component to the kids with ADHD, because if you give them a stimulant, it might bring out their bipolar disorder. There was another study that looked at the incidence of bipolar disorder diagnosis in the US compared to the UK. In the UK, where they're not as aggressive in diagnosing or treating kids with ADHD, there's a much lower exposure to stimulants, and there's also much lower diagnosis of bipolar disorder. So the British psychiatrists think that we are causing some of the childhood bipolar disorder by overdiagnosing and overprescribing stimulants for ADHD. Another thing to look for, of course, is the antidepressant-induced agitation or activation. What are some other things that you can look at in diagnosing your kids with mood disorders or bipolar disorder? One is look at the illness and the chronicity. So just like with adults with bipolar disorder, often you want to have a chart. There's a good chart that's available online. I think the National Institute of Mental Health has a template for a mood chart for your adults with bipolar disorder. There's other charts that you can use with your patients, or their moms rather, to chart their kids' moods. You want to look at, is the condition frequent? Is it chronic? Are there mixed symptoms or rapid cycling mood states? One thing that you'll see is that irritability is very common. There's the irritability word that came up again. And the explosive outbursts are frequent. What you want to do when you're diagnosing these kids is you want to find discrete episodes if possible. One thing to keep in mind is that bipolar disorder is a mood disorder, so without symptoms of mood disruption, you don't have bipolar disorder. So you'll find mood lability and affective instability in these cases. So in every case of bipolar disorder, there should be components of mood instability. It is a mood disorder. Sometimes mood congruent psychotic symptoms, but that's not often. What are some comorbidities with pediatric bipolar disorder? ADHD is very common, and there's an overlap with ADHD. Substance abuse, anxiety disorders overlap, oppositional defiant disorder, and also conduct disorder. There are certain ways to distinguish between ADHD and bipolar disorder. 5 symptoms tend to help us distinguish the conditions the best. Elation, grandiosity don't occur frequently in ADHD. Of course, flight of ideas and racing thoughts can be seen in our adults with bipolar disorder, and certainly if you see them in a kid or a teenager, it's a clue towards bipolar disorder, decreased need for sleep, hypersexuality. Of course, there's no brain or blood test yet. There are some biomarkers that are being explored and being looked at, such as the cortical frontal development, but we keep waiting for the day for a blood test or a brain test, and there's clues, but it's not here yet. So at this point, we're still reliant on history and phenomenology. This slide emphasizes what are the symptom differences and characteristics that you see in ADHD and bipolar disorder, and you can see that those 5 symptoms, the elated mood, grandiosity, flight of ideas, racing thoughts, decreased need for sleep, and hypersexuality, if you look at those 5 symptoms, they separate very nicely between bipolar disorder and ADHD. For example, racing thoughts was only seen in 1% of kids with ADHD compared to 50% in bipolar disorder. What this graph is meant to convey is that pediatric bipolar disorder is more of a spectrum condition. It may not be a distinct condition that we can pigeonhole neatly into one category. There's a spectrum, and what you see is perhaps ADHD with a family history of bipolar disorder, depression with a family history of bipolar disorder, some kids with bipolar disorder not otherwise specified, meaning the atypical presentation, and underneath that, the bipolar NOS or atypical bipolar is cyclothymia. Maybe that's a variety. It's certainly within the spectrum as well, and then more of the classic bipolar 1 and bipolar 2. We'll mention psychosocial and behavioral treatments for the bipolar disorder for the sake of completeness. I don't go into that too much, but every visit with a child with a mood disorder should also include some psychosocial treatments, or at least monitoring or emphasizing the importance that diagnosis and medication treatment is not all that there is, because we'll see that the medication is at best only partially effective. What are some goals and things that you can do with psychosocial treatment? One is family-focused therapy, because the child does not exist in isolation, they exist in the context of the family, and you want to work on increased communication in the family. You want to educate the patient and the parents what prodromal symptoms may look like so that they can intervene before it gets totally out of control. I always say if you can catch it early, then you can oftentimes forestall or prevent a complete meltdown. The other thing is you want to talk with the patient and the family about their beliefs of medication, emphasize the importance of adherence to medication, because oftentimes it's years and years. It's not just treating for an episode and they're done. It's a more chronic condition. There's something called interpersonal and social rhythm therapy, and it's super important for these kids, just like the adults, to help stabilize their daily routines and their sleep-wake cycle. Work on their personal relationships, insight into their moods, and track their sleep activities and mood. Also, cognitive behavior therapy. These kids can be in therapy with an outside therapist, or if you have the luxury of doing some psychotherapy with them, you can monitor their moods, their prodromes, have some interventions to help with their mood swings, and so on. So I'll move to the psychopharmacology for pediatric bipolar disorder, which is a rapidly evolving field. A number of treatment options medication-wise for bipolar disorder. One is the traditional mood stabilizers such as lithium. Antipsychotics are used frequently. Anticonvulsants such as Depakote, carbamazepine, and lamotrigine. That's what the LMT is there, lamotrigine. We talked about the psychosocial approaches, such as looking at the course and the prognosis. Oh, I've got some water, thank you. Family therapy, behavior modification. And also, I call them contingency planning for behavioral emergencies. In other words, fire drills. In other words, practicing what to do if the child's having an outburst when they're not having an outburst, so when it happens, you know what to do. A number of studies have been done to look at these different medications: lithium, Depakote, carbamazepine, oxcarbazepine, and lamotrigine. But there's not too many double-blind, placebo-controlled studies. Lithium is the one that's been studied the most, and the double-blind, placebo-controlled study's been done for adolescents. We're not going to go over this in more detail. It's just to show you that some of the studies that we have are not the gold standard double-blind, placebo-controlled. However, if you look at the effect size, in other words, how effective are these treatments when kids are given the Young Mania Rating Scale, if you look at the medications compared between youth and adult, you see some real differences. The effect size for lithium, for example, with adults is 0.5. For youth, it's only 0.3. For divalproex, it's half of what it is for adults at 0.28. Carbamazepine has an effect size for adults, but hasn't been studied that well for youth. And oxcarbazepine, we don't use much anymore because the effect size is only shown to be 0.11. So that was a prescription that was given maybe 10 years ago, but it's not much anymore. And this finding of topiramate didn't separate out in youth. It was found to be 0.51. It's really not that strong. So let's talk about lithium for a minute. So lithium has been the mainstay of treating bipolar disorder in adults for over 50 years, since it was discovered by John Cade, the Australian psychiatrist. It is approved by the US FDA for acute mania and bipolar disorder in adolescents aged 12 to 18, although some people have said if lithium had to go up before an FDA review board today, it wouldn't get approved because it has such a narrow therapeutic range and so many untoward side effects such as kidney problems, thirst, toxicity, and so on. But it's there, it's approved, and it works. It's the best studied of all the agents we're going to go over. functions by various neurotransmitter effects. No one knows exactly how it works, but it does work on serotonin, norepinephrine, dopamine, and increasing GABA. It probably has effects further down in the cellular and subcellular level, such as alterations in ion channels and intracellular signaling. And the thing that I use sometimes in discussion with my patients is that lithium has a neuroprotective effect. There's a good slide that I don't have duplicated here, but it shows that lithium actually protects from neurodegeneration in the amygdala. So it's called a neuroprotective effect. And that's what we hope to achieve with our patients, that we can actually protect their brains and help them to heal. One thing that we find is that although lithium has been used, oftentimes we have to supplement with mood stabilizers to treat the agitation. Even though these are second-generation antipsychotics, they're frequently not used for the psychosis. I'm going to try to go a little quicker here. Besides lithium, there's some other anticonvulsants, such as Depakote, divalproex, and carbamazepine. In the interest of time, I'm going to skip to the atypical antipsychotic slide because these have a more robust effects. The atypical antipsychotics are also what we call the second-generation agents. Risperidone and aripiprazole are actually FDA approved for treating bipolar disorder in adolescents. Olanzapine and quetiapine are used off-label. Geodon's not frequently used in my practice. There is benefit that's conferred by monotherapy with mood stabilizers. There's demonstrated effects on mania, psychotic, and aggressive symptoms. However, we find that adding the atypical antipsychotics produces a more robust effect. The reason that the field has shifted towards using the second generation is, of course, they have a side effect profile that is better tolerated than the typical antipsychotics, such as lower incidence of EPS, tardive dyskinesia, and so on. Again, these have been mostly open trials. Risperidone and olanzapine have had positive studies. Quetiapine separated as better than divalproex. Ziprasidone did not separate. And aripiprazole, this is an older slide, actually had positive outcome as well. Risperidone is used in monotherapy and actually has a FDA approval now. The CGI score in a study of 28 youths showed very much or much improved at 82%. The side effects of these agents are their downfall, however: weight gain, sedation, some extrapyramidal effects like akathisia, and so on. Aripiprazole is indicated now for maintenance treatment of mania or mixed episodes. It's also FDA approved for adjunctive therapy to either lithium or valproate for acute manic or mixed episodes. Side effects are akathisia, sleepiness, EPS, fatigue, nausea, blurred vision, drooling, dizziness. So these medications are not without their side effects. Here's a graph of quetiapine in adolescent psychosis, and there's also a graph bar here for the Young Mania Rating Scale, which showed improvement with quetiapine as well. So what are the effect sizes? We looked at that earlier with lithium and some of the mood stabilizers. What are some effect sizes that we see with these second-generation antipsychotics? What we see is pretty robust effect sizes, especially for aripiprazole and olanzapine. I'm not going to go over all these numbers. You can see them yourself. For aripiprazole, the effect size was 0.69. Adults 0.36. It may not be completely accurate, but I think of effect size as how effective these agents are. That's why it's called effect size. Doesn't mean that it's going to be effective in 70% of the people. However, it may be 70% effective for symptom reduction. That's the quick way to think about effect size. Olanzapine had an effect size of 0.75, but olanzapine, as we know, has a very high risk of sedation, which was helpful on Sunday night for my 2 patients at the CRC, who were not adolescents, by the way. But they definitely benefited from that effect for their mania. Quetiapine, of course, is very sedating as well. Risperidone had the best effect size here of 0.81, and that tends to be my first choice in treating kids with bipolar or mixed moods. We start with something like risperidone because not only is the effect size good, but the clinical confidence index is very good too. It's the community standard or treatment of choice. Furthermore, there was a study that just came out. It was called the TEAM trial, multi-center treatment of early age mania. It just came out towards the end of 2011, and it showed that risperidone was more effective than lithium or divalproic for pediatric mania. They took patients aged 6 to 15 with untreated bipolar I, manic or mixed episodes, persisting for 4 weeks, randomized into these 3 medications: risperidone, lithium, divalproics. Mean age of 10, average duration of mania 4.9 years. That's a long time. If you just look at that, how many of your adult patients have persisting average mania duration for 4.9 years? It's a long time. And that's what we see with these kids with pediatric bipolar disorder. It tends to persist, it's chronic, goes on for a long time. Elevated mood or grandiosity occurred in 100% of patients. We talked about that earlier, how that's one of the separating criteria from ADHD. You won't see the elevated mood or grandiosity in your patients with ADHD. Same with psychosis. These kids had mixed mania and daily rapid cycling. And the findings showed that risperidone had a treatment response of 68.5% compared to 35% for lithium and 24% for divalproics. However, what you see with these agents, the second generation agents, of which risperidone is one, weight gain and hyperprolactinemia. So there's the cost that these come with of metabolic effects. There is significantly more weight gain and increase in BMI and prolactin levels with risperidone. Now, risperidone has the highest prolactin elevation of most of the second generation agents. I've seen kids with gynecomastia and lactation, and even boys with gynecomastia. One boy who required breast reduction because of risperidone. So it's not to be taken lightly. There was an open-label trial of olanzapine. Dose was maximum 20 milligrams. Overall response rate was 61%, but it did show significant improvement on 4 standard rating scales. Here's a graph showing that. Same with quetiapine. There was demonstrated improvement. Also, one branch of this study showed quetiapine plus divalproics, indicating a significantly greater response from baseline than the divalproics plus placebo group. Now, that combination I call my dynamic duo, and that's one of the big guns that I was talking about, divalproics plus quetiapine. I don't think 2 medications can be any stronger than those 2 in combination, and some of my toughest to treat, most disabled rapid cycling kids I saw on Depakote and Seroquel, which are the brand names of quetiapine and divalproics. I had some kids on, and this is off-label, 1,000 milligrams of Seroquel and 2,000 milligrams of Depakote. I didn't push the dose that high very frequently, but there were some kids that were on that high a dose. But that's off-label, not FDA approved. Sedation and weight gain were greater in the quetiapine plus divalproics group. What are some treatment emergent side effects from the second generation agents? most common sedation, weight gain, less common extrapyramidal side effects, gynecomastia, galactorrhea, and amenorrhea, especially with risperidone that increases the prolactin level. Relatively uncommon are diabetes, tardive dyskinesia, and neuroleptic malignant syndrome. This slide emphasizes the incidence of weight gain in these second-generation agents, and you can see olanzapine in orange here and risperidone in blue had a significant weight gain. Olanzapine, the worst, of 7.2 kilograms, about 15 pounds. Risperidone, 4 kilograms, about 8 pounds. Haloperidol, 1 kilogram, about 1 pound. So let's sum it up now. What are some treatment strategies and what should you implement when you suspect a child has a severe mood dysregulation disorder, or even if you've done the diagnostic criteria and you think that they have bipolar disorder? Well, what we want to do in clinic is strive for monotherapy. You don't want to jump on board right away with the 2,000 milligrams of divalproex and 1,000 milligrams of quetiapine. You start low and go slow. That's our clinical maxim in child adolescent psychiatry, also in geriatric psychiatry, of course, start low and go slow. Usually you want to consider the atypical antipsychotic, and that's the evolving standard of care in the community, that you use monotherapy with an atypical agent such as risperidone or aripiprazole. One of the problems with aripiprazole is that there's a subset of kids that get activated from it. It's a little bit of a tricky medication because at the lower doses it can be activating, and you have to push it up a little bit to the 5 or 10 milligrams to avoid the activation. And of course we start it low. So I've had that problem sometimes with aripiprazole, whereas risperidone, you don't see that. Another treatment strategy, what you want to do is look for the comorbidity, because oftentimes these kids present with ADHD or oppositional defiant conduct disorders. The important thing is to treat the bipolar mood symptoms first, because that's oftentimes your clinical priority. However, if you don't have a robust response, that's the time to pick up on the comorbidities. As we mentioned, treat the mania and hypomania first, treat the depression next, then look at the comorbid condition. The atypical second-generation antipsychotic agents tend to have a more robust treatment response, especially for mania with aggression and irritability. Side effects from the atypical antipsychotics we mentioned are sedation and, of course, the metabolic effects. And it's very important at the outset to monitor for these metabolic effects. At baseline, check weight, blood pressure, fasting blood glucose, lipid profile, family history of cardiovascular disease or dyslipidemias, and monitor for obesity and BMI and blood sugar every 3 months. Treatment considerations when implementing these medications is to avoid sedation. You want to minimize the metabolic effects on weight, blood pressure, triglycerides and lipids, and also on fasting blood glucose, and take into account family history, including cardiovascular disease, obesity, and diabetes, and monitor the metabolic risk factors and BMI every 3 months. Thank you for coming today. I'll take some questions now. And I'd say that not all 5 of these are my girls. Yes.
John, thank you very much for an excellent and lucid presentation.
Thank you, Dr. Acey. Go ahead.
The one area that I still have trouble with is diagnosis. Having told us that the presentation in children is atypical, that they may not be elated but just irritable and misbehaving and having outbursts, and they may not be episodic, that it can be continuous. I have great trouble distinguishing it from disruptive mood dysregulation and severe mood dysregulation. So does it really come down in reality for you to make the diagnosis and not overdiagnose to family history? Is that the key element? I'm searching for a way to hold on to it.
You know, it's a very good question, because I think that that is an open question, and that's what the field is looking at right now. One of the primary authors is Barbara Geller at State it's an open question, so I can't answer that completely. What the astute clinician does is look at which symptoms are causing the most problems. Why is a child in your office? Is it because of mood dysregulation plus conduct problems? Is it mood dysregulation in the context of ADHD and oppositional defiant disorder? And then you tailor your treatment that way. So in some ways, it's better not to diagnose bipolar disorder because you really don't have to. And what I try to do, and my colleagues that I've seen do the same thing, diagnose mood disorder NOS. And mood disorder NOS, which is 296.9, encompasses these conditions, and it justifies treatment with mood stabilizers, second-generation agents, and still includes the comorbidities, which you can list as a secondary axis 1 or axis 2. So it's hard to answer that question. I would say stay tuned. And I can give you a copy of the paper by Ellen Leavenlund where she discusses the boundary issues between mood dysregulation, irritability, and bipolar disorder. Because there's basically two camps. There's ones that are the, hold on a second. There's the narrow camp that wants to have more specific diagnostic criteria, and then there's the more broad camp. And I think that that's a tension within